Welcome back to Meet the Author from Neurology Education, the podcast where we meet the people behind the projects and hear the stories behind the studies impacting neurology education today. My name is Harry Sutherland, and I will be your host today as we explore resident perceptions surrounding consults. I'm excited to be joined by Dr. Stephen Krieger of the Icahn School of Medicine at Mount Sinai, who is the senior author of The Inappropriate Consult, Discordant Expectations of Specialty Expertise, and Areas for Improvement in Interdisciplinary Resident Education, published in Neurology Education, March of 2023. Thank you so much for joining us on the podcast, Stephen.
My pleasure, Harry. Thanks for choosing this paper and for having me on.
This is a classic, and I'm excited to get into it for our listeners. So this study included two phases involving 65 residents at a single large academic medical center. In phase one, neurology and internal medicine residents were presented with 10 clinical vignettes and asked to reflect on expected and aspirational generalist versus specialist knowledge of the case and on the appropriateness of the consultation. And then phase two followed 3 years later after the implementation of a 2-week neurology consult rotation for medicine interns and included similar case vignettes as well as semi-structured interviews. So that's an overview of the project, but Stephen, I just wanted to ask you first, what inspired you to pursue this study? What got you interested in the area?
Well, having been a neurology trainee, a neurology resident, and knowing that kind of guttural feeling of frustration when fielding a consult request that you just feel is just inappropriate, just not necessary, and knowing that feeling and being cognizant of it throughout my training helped me when I became residency director at Mount Sinai in overseeing my trainees and to try to help them to not succumb to frustration and burnout and that sensibility as to what was appropriate or inappropriate. Then I decided to explore it and say, what is that feeling? Where does it come from? What can we do about it? And to make something academic out of it. And it's basically a social psychology research project to understand what people think they're supposed to know and what other people are supposed to know about their area of expertise.
And I imagine that understanding the expectations and realities of consultation didn't completely fix the issue for all of your residents. I'm curious how you use the results when talking to perhaps frustrated residents that are coming to you saying, hey, I got this call, I'm kind of frustrated by it.
Right. I think understanding where the frustration comes from is helpful. So the data that we sought to acquire here was trying to bolster an understanding of where that came from. And, because as a program director, you're one part mentor, one part boss, one part therapist. And I think that you have to try to approach it in all those ways. So, the conceptual background to it was this notion that what we know, what anyone knows, they feel should be rather self-evident to other people, that their knowledge should be universal. So I think neurologists in training feel that what they know is not so rare. Everyone else who's gone to medical school and is a resident should be familiar with these things. So that's one thought. And the second thought is, if you encounter something as a clinician or as a doctor that you've never seen before, that you don't know how to handle, I think the tendency is to think that it must not be very common, it must be unusual, it must be someone else's expertise. It must be someone else's problem. And those are the two fallacies. Everyone thinks that what they know should be obvious to other people, but that what they don't know is special and should be someone else's problem. And those fallacies kind of come into conflict with one another in thinking that every request for your expertise is inappropriate. So it started from a place of trying to guide residents to say, well, can we be more generous with our knowledge? Can we take on an educational mission when we do consults that we feel are inappropriate, to teach the other team, what needs to be done or what they need to understand. And on a fundamental mentorship level, it really is to remind a frustrated resident that at the end of the day here, there's a patient in a bed that needs care. And the team that's consulting you is asking for your help. And our job is to come give it. And so although the project was framed as the inappropriate consult, really the underlying principle is it's never inappropriate to help a patient. It's never inappropriate to help your peers across disciplines, and how can we better understand those frustrations to help minimize that?
Absolutely. Very well said. We're all coming together to help our patients and help each other. And I think that this theoretical framework that you put forward in the paper that you call the dual fallacies, I think is a really interesting insight. And again, between those fallacies of, well, I know this, everybody should kind of know this, versus I don't know this, I'm not expected to know this. That's a very interesting conflict that you pointed out. And so if people want to read a little bit more on this, I would highly encourage them read this paper that explores that dual fallacy perspective and theoretical framework. So, Stephen, from your perspective, what are some of the most important or perhaps surprising findings from your study?
Well, I think it was a survey study. It doesn't always replicate real world perfectly, but we posed these vignettes to, number one, see if the neurology residents knew the neurology better than the internists, and the internal medicine cases to ensure that the internal medicine residents knew those answers better than the neurologists. And then we asked these questions as to whether this is something they should know, whether this is something the other team should know, and whether it's an appropriate consult. And for the most part, the results followed the themes that we set out. But not always. In fact, one of the ways that the results differed a little bit from what the hypothesis would be is that both fields, in essence, thought that they should know more than they do. I think that's a great finding. I think what that means is there's some humility involved and a recognition that people would like to know more than they do. So it was a little bit less of, this is not my problem. And the intervention that happened between phase 1 and phase 2 of the study was to establish a rotation for the internal medicine interns, the PGY1s, on neuro. That hadn't existed before. And so in some ways that could mitigate the internal medicine residents' perception of what's appropriate or inappropriate. Since they rotate through our consult service, they see it from the other side. It probably wouldn't and didn't change the neurology residents' perspective of things, but keeping in mind that neurology residents, of course, spend a year as interns, and so we do have that broad spectrum medicine exposure. That comes up in some of the structured interviews where the internal medicine residents who were interviewed sort of said, well, neurology residents should know how to answer these questions. They've spent a year in internal medicine. So that sort of validates that principle a little bit. Now, it's a survey study, and survey studies don't always replicate the real world perfectly. And so what I think the survey gets at is some of these intellectual ideas. What a survey doesn't necessarily invoke is the feeling of frustration that one actually has when getting a consult request on a busy day and feeling that their time would be better spent doing something else, that it's inappropriate in that way. So we actually did a paired study where we did this in real life, having two of our medical students who are both now finishing their neurology residencies. That's how long it took to get that done. Emma Lobel at Mount Sinai and Caroline Gentiles at Penn. But we've embedded them in the consult service and had them ask questions of the person requesting the consult about how appropriate or inappropriate they thought it was, and asking the people who received the consult, the neurology resident, how appropriate or inappropriate they felt it was. So we had a real world version of this that I think brought out more of the frustrated qualities and the kind of lived experience of being in training. So that's kind of a companion paper that was published in The Neurologist. But the piece published in Neurology Education is really the principle. And it's really the ideas of how these fallacies come about, how they affect us in our practice as trainees, and then a variety of recommendations for how to make things better.
Yeah, certainly interesting to see how things outside of the laboratory of your study in the real world with embedded people on the team panned out and may differ. You mentioned earlier that people in both groups, both the neurology trainee group and the internal medicine trainee group, wanted more knowledge for themselves, which is admirable. It demonstrates a growth mindset that people are still forming their professional identities. And one thing that I thought was interesting was that the internists thought that they should know more neurology than the neurologist expected of them. And I was kind of curious what you made of those results.
So I think it's good. It's a positive outcome in a lot of ways that, they wanted to know more neuro than even the neurology residents thought was warranted. So that does not, thankfully, validate the depth of the dual fallacies problem. And I think that that's good. And I think it's aspirational. And I also think that it opens up a pathway to trying to improve interdisciplinary care and education. If the internal medicine residents, at least at this one institution, presumably that's going to be true in other great training programs as well. But if the internal medicine residents want to know more neurology, think that they ought to know more, then that is a beautiful setup to have more and better interdisciplinary training around common consultation topics, common scenarios that are encountered by both internal medicine and neurology, particularly in the hospital. So that informed some of our conclusions about ways to address these problems and ways to address these fallacies through interdisciplinary education.
And beyond the knowledge assessment, you then asked people to rate how appropriate a consult was. And you actually found that neurologists were less likely than internists to deem a medicine consult as appropriate. And I was wondering what you thought might explain this discrepancy.
Yeah, perhaps this was in part due to the vignettes that we selected. We tried to come up with things that would invoke the problem, as it were, the sense of inappropriateness. But I think the internists, or at least the internal medicine residents that we surveyed, felt that these questions were reasonable for them to come and answer. And, perhaps if we'd had a broader array of vignettes, more challenging ones or a more mundane one, we might have seen a little bit more resistance to the idea that it would have been an appropriate internal medicine consult. So we didn't have a validated tool for this. I should say this was a completely de novo project where we had chief residents at the time help write these vignettes that seemed to be reflective of knowledge-based expectations and common scenarios. But, if all of the scenarios were extremely esoteric, then everyone from both teams would have thought that they were all perfectly appropriate consultation questions. If they were all completely mundane, then it wouldn't have been as interesting either to go too far the other side. So we tried to hit a sweet spot.
And it seemed like with regard to consulting the neurology team, it seemed like there were approximately similar expectations on both sides. Turning next to the process, every paper, every project is a story from initial conception through final publication. So did you encounter any challenges along the way of taking that path?
It's a great question. So this project took a very long time from initial conception to when that paper finally appeared in Neurology Education. That's partly why we had two phases of the project. When it was first done, when we did the original survey, that was before we ever had an internal medicine rotation on neurology. When we made that rotation, it seemed like an opportunity to do a second pass at this project and have a sort of a before and after. But, one challenge I would say is I didn't have a before and after concept, a pre-test and post-test concept when first doing the initial end of this study. And I would encourage anyone who wants to do education research to really think that out in advance. What the intervention is going to look like and how are you going to assess things afterwards. So this was done in a somewhat organic way. That certainly added a couple of years to the process. One thing I'm proud of with this project is that I had student collaborators and resident collaborators with it all the way through, and it was presented as abstracts at the American Academy of Neurology meeting on a couple of occasions, at some local conferences, at a New York neurology conference. So one of the advantages was the amount of attention that it got to our student presenters along the way. There was always a crowd around these posters. And I think just the title, Inappropriate Consult, was so activating for people. Everyone had a story to share with our trainees at these conferences. So that wasn't a challenge so much as a pleasure about this project. But I think the challenges were in seeing it through, in making sure that our students and trainees were able to carry these papers through, the one in the neurologist and the one, of course, in neurology education that Charles Sankey first authored. The revise and resubmission process is always challenging. And I encourage any trainees who are working on their manuscripts in this respect or their projects, think of posters as free peer review. Everyone who comes to your poster and has things to say, write those all down. That's great advice that you can then figure into a manuscript. And then, of course, view the peer review process as a iterative rather than frustrating towards the goal of landing your work in a journal.
Yeah. And also, if anybody's looking for an opportunity to become a peer reviewer, that also gives you very rich insights into how to become a better author for your projects. But I think that what you mentioned about this being something that arose very organically from the clinical environment and maybe not from the outset having the strictest parameters in terms of outcome assessment and what to do with them, you do provide some very interesting ways of implementing some of the findings from your study. So I wanted to see in their interviews, residents offered various technological, educational, administrative solutions to combat these discordant expectations surrounding consults. And you share these in the results and discussion section of the paper. And I think that it's a fantastic resource for people struggling with this problem at their institution to refer back to. But Stephen, what do you think are some of the most practical and easily implemented changes and solutions identified by your residents that our listeners could consider adapting at their own institutions?
It's great. I mean, one of them, the simplest one, is just simply an awareness of the cognitive problem that happens when faced with a consult that you think is inappropriate or frustrating. And so just the self-awareness of that and the reasons that go into it, I think helps in the moment. And this is a very much of an in the moment kind of phenomenon, which is another thing that a survey doesn't always get at, because you have the opportunity to sort of dispassionately think about it and fill out a survey as opposed to the in the moment feeling. But viewing consults as an opportunity for education was one of the things that kind of came up. And so to view them as an opportunity to inform another team what the principles are, what the diagnostic question is, how to prioritize things. One of the salient things that came out was that an appropriate consult is one that asks a specific question, an answerable question, ideally, but a specific question. And so trying to frame one's own consults in that way, I think, is important. And I point out to our own trainees, when neurology residents consult orthopedics, for instance, we're not asking, in all likelihood, a very provocative, interesting academic question, a hot topic in orthopedics that's going to really be stimulating to them. Basically, we're calling and saying, my patient has a bone problem. Could you come see them? And when orthopedics consults neurology, they're going to say the patient has a brain problem. Could you come see them? Trying to frame a question in as answerable and specific a way as possible, I think, is generous to the other team, and it makes for maximal efficiency. We've tried to sort of institute some educational resources in the consultations. So with the electronic medical record and with templates, you can sort of build in and structure responses to kind of standard consults, so that there's always a little bit of an algorithm there and a workflow there that you can put into the consult note or put into the consult request to sort of facilitate certain things being done either in advance of the consult or afterwards, both from a care perspective and from an educational perspective. And then I mentioned earlier interdisciplinary education. So I think in your institution, if there are certain scenarios that commonly come up, altered mental status consults and people with infections, things of that nature, one could have a nice interdisciplinary noon conference or morning report type event for, let's say, neurology and internal medicine to kind of come together, do some teaching together about it. And I think those go a long way. And they also build a culture of collaboration, which I think is really important here too.
Absolutely. I think that there's so much to be said about just having that sense of community of your peers and fellow practitioners. So some key takeaways that I took from this study, and Stephen, I may ask you to supplement where you see fit. Some key takeaways that I took away as a reader from this study are that, number one, there is a dual fallacy where trainees, as they differentiate, presume that their own knowledge is common across disciplines, whereas unfamiliar topics are beyond their scope. 2, neurology and internal medicine residents have already begun to specialize their knowledge, with each group answering more questions correctly in their own specialty. 3, neurologists and internists both help themselves, and residents in the other discipline ought to know more neurology than they actually did. Number 4, neurologists and internists rated the appropriateness of neurology consults similarly, but neurologists were less likely to feel a medicine consult was appropriate, and we got into some reasons for why that may be earlier. Number 5, residents agreed that ideal consults should formulate a specific question and should follow an initial workup, but they felt that this rarely happened in actual clinical practice. They voiced that some consults had low educational value, may be motivated by medico-legal liability, and expressed that workload adversely impacted consult quality. Number 6, the residents identified 13 factors that influence the appropriateness of a consult, spanning educational, communication, clinical, and administrative domains. And then finally, number 7, residents proposed several specific solutions, which again, I highly encourage you to refer back to the paper in Neurology Education, but they proposed these solutions to address discordant expectations surrounding consults, and these are again described in the full text. Any other key takeaways that you would want our listeners to take from this podcast and from your...
Well, I think that's a wonderful and close read on the paper. I think you summarized it better than I could at this point, so I appreciate that. I guess the last thing I'll say, which is just for fun, is a comment about promoting one's ideas and getting one's ideas out in the world. And so we started this project quite a number of years ago, and I had watched with amusement the rise on social media of Glaucom Flecken and his neurology impersonation as really kind of embodying a lot of the things that we're studying here. And the frustrations. So for all of you who are familiar with his take on neurology, I mean, it's unflattering, but it's amusing that we think that we're the smartest folks in the hospital and everyone else is essentially asking us stupid questions all the time. And so we cited that in the paper as sort of evidence of the familiarity people have with this problem. And then when we published the paper, I put a Twitter thread, it was then known as Twitter, now X, about the paper and tagged Glaucom Fleckum in it. And he was amused enough by it to retweet it himself to his some 750,000 followers, which definitely increased the visibility of the paper. And so one note I would say is if you have something that you think can catch the popular interest and get it into the scientific literature, it doesn't stop when you publish it. You want to try to then push it out into the world. And this was a great way of getting a lot of visibility to this project, which I think was amusing and quite gratifying at the end of the whole story.
Absolutely. There's certainly something out there because, as you said, people are coming up to you and all of these posters sharing their stories. There is this lampooning of neurology consultants in Dr. Glaucom Fleckum. So this is certainly a phenomenon that we all have some kind of experience with, but not many people are talking about and publishing on it. So thank you for bringing this into the medical literature.
Well, thanks again for featuring it here, Harry, and for all the work you're doing. On behalf of Neurology Education, I'm so happy that that journal exists as a venue for things that we all care about. So thanks again for having me.
Right. So that's all for today's episode of Meet the Author from Neurology Education. I've been speaking with Dr. Stephen Krieger of the Icahn School of Medicine at Mount Sinai about his paper, The Inappropriate Consult, Discordant Expectations of Specialty Expertise, and Areas for Improvement in Interdisciplinary Resident Education. Listeners can find the manuscript on the Neurology Education website, and the link will be provided in the show notes. Stephen, thank you for joining us today.
Thanks again.
And I have been your host, Harry Sutherland. Thank you for tuning in, and remember to come back next month for more author interviews. Until then, keep innovating in neurology education.